Hello, good afternoon. First of all, I would like to thank the organizers for inviting me to present at your presentation. This is a very important subject. Today, I have been given the responsibility of talking about benefits of preoperative education in elderly patients with emphasis in analgesic use. The outline of my presentation will be as follows. We'll discuss a little bit about the history and how we perceive geriatric patients. I think before we talk about analgesia, we need to understand what changes happen with aging and what are some significant pharmacokinetic and pharmacodynamic changes that happen with aging that affect our anesthetic drugs as well as our drugs that we use to manage pain. We will then talk about a little bit about preoperative evaluation and some pain specific issues that should be determined or at least discussed with the patient or patient's caregivers. Finally, we will talk about the analgesic plan and education and then some summary of recommendations. Now, preamble. So, geriatric and perioperative geriatric care is not a new topic. You can see this mentioned about even 100 years ago. The only difference that has happened is that who we consider elderly keeps on changing. When the topic was being discussed between 1920s and 1950s, somebody who was older than 55 was considered geriatric. So by that standard, I would be considered geriatric. In the 1960s, especially when the Medicare bill was passed in the US, the cutoff that they decided that somebody was older and can be eligible for Medicare was greater than 65 because a very small percentage of the US population was older than 65. And hence the concept that older than 65 was considered geriatrics. Over the subsequent decades, as the life expectancy has increased, people have used different generation. And now some people consider individuals older than 80 years as geriatrics. One definition of geriatric is anybody who is older than 15 years of the person who is defining geriatric. So anybody who is 50 years older than me, I would call them older. So it doesn't necessarily matter what age they are. So that's just beside the point. Now, if you look at 2018 in the US, the expected age at birth or life expectancy was somewhere between 79 and 81, and hence the word octogenarians were the new elderly. If you look in Colombia, based on the World Health Organization information, the expected life expectancy in males is about 71 and in females is about 79, and hence the average life expectancy is about 75. So one can argue that even in Colombia, somebody who is older than 75 or 80 would be considered geriatrics. Before we move on further, I would like to mention what happens in the studies. So there are many studies that talk about individuals and discussing elderly and geriatrics, and their cutoff is 65. But all elderly patients are not the same. So this is one of our late presidents, Senior Bush, and when he took office, he was 67 years old. The same Senior Bush would also be considered elderly, but as you can see, that 67-year-old is very different from the 91-year-old. However, in our studies, we tend to extrapolate a lot of information from younger population to very old populations. And sometimes that skews the data, it confuses the data, and essentially is not relevant to the patient that we are looking at. So something to keep in mind when you are reading the studies about geriatrics and elderly patients as to what their cutoff is, what is their average age, and does that really relate to your patient that you are taking care of in the clinic, in the operating room, or post-operatively. Next topic is what are the changes that happen with aging. Now, there are many changes that happen with aging in the central nervous system. They involve broad structural changes, they involve changes in the synapses, they involve changes in the receptors, and they involve changes in connectivity. If you look at receptor changes, if you look at GABA receptors, what happens is there is no change in the numbers, but it seems like that there is a change within the receptor which causes increased iron and chloride fluxes, which increases the sensitivity of drugs that work on GABA. Similarly, for individuals that are glutamate, now glutamate is an excitatory neurotransmitter, that is decreased, and hence there is increased sensitivity of drugs, anesthetic drugs, in the elderly patients. NMDA is involved in pain pathways, but also it is involved in creating connections. There is decreased number and decreased function, and hence drugs that work on the NMDA receptors would be causing increased sensitivity and decreased plasticity. Opioids that are used for pain management, there is no change in number of receptors, but there is decreased tolerance and there is some increased sensitivity of opioids based on the changes that happen in the receptors. Now, if you look at anesthetics, anesthetics generally were thought to work on the brain and put the brain to sleep. But keep in mind that in an average human brain, there are about 100 billion neurons, and each of the neurons can create up to 10,000 connections. So even if a connection is made by one neuron to another neuron, you probably have about 100 billion connections in the brain. If you multiply that by 10,000, you are talking about tens of trillions of connections, and that's probably more than all the router connections that we know of in the world. So these brain parts are essentially organized into different anatomic areas and functional areas. What is the functional significance of knowing that these areas are anatomically and functionally organized? So the simple model is such: we have inputs that come, they pass through the brainstem, they enter the thalamus, they then are transmitted to the parietal cortex and the frontal cortex and other parts of the brain. Now keep in mind the flow of information is not one sided. Each part is constantly talking to each other. That means they are in constant communication. It is like thinking about a computer where you have the memory, the hard drive, you have the motherboard, you have the power supply. Now, any disruptions between these components will lead to a screen that will be blank, and you would say, "Oh, my computer has died, or my computer is not functioning, or my computer has gone to sleep." Doesn't necessarily mean that all parts of the brain are asleep. It just sometimes is the disruption of connections. So the simple model of how anesthetics works, at least at the connection level, is that they disrupt connections by acting on specific areas of the brain, which ultimately leads to a state that we call anesthesia. And that involves analgesia, amnesia, and immobility. And obviously, we want to keep the patient alive while this is happening. Now, what is the importance of understanding that there is this connectivity? Connectivity is a very plastic process. It is constantly evolving and changing, and hence, as we age, the connectivity changes. And this is one of the older studies published about 5 years ago, and now we have data supporting a similar phenomena what happens is that initially the connectivity becomes more specific, and then, sorry, the connectivity becomes more specific, um, and then around the age of 70, 65, 70, you start to lose that specificity, and hence you see this change in specificity. One of the ways to mention the connectivity model is to present different parts of the brain connecting to each other. The bottom line is this, that as we age, even though there is increased connectivity, that means different parts of the brain may be connecting more, it actually leads to less distinction and becomes less specific. In simple words, the brain becomes a little more mushy. Now, what is the clinical significance of that? The clinical significance is that when you have too many connections, even if a small part of the brain is affected, it is going to have a much wider consequence. Now, that is the hypothetical assumption that that may be one of the reasons that even apart from increased sensitivity to anesthetic drugs and analgesic drugs, that the elderly are more predisposed to delirium and cognitive dysfunctions and disabilities involving the CNS, because so many parts are connected. So even a slightest disruption can lead to probably much more of an effect. Now, coming to our topic of pain, what I want to highlight in this part is that pain is not only just determining where the pain is coming from, but it also, these pain pathways also are connecting to areas that are involved with emotion and our cognition. Okay, recognizing the impact now, and also connected to the parts that affect the sympathetic outflow. So the emotional and cognitive components of pain cannot be underrated, because how we perceive pain, how a person perceives pain is going to be significantly affected, and hence how much medication and interventions they require to manage pain is going to be affected. So, this is something that you have to keep in mind. Furthermore, the body changes. There is, as you can see, decrease in muscle mass as we age. Hence, the weight or proportional fat increases and the lean body mass goes down. This happens more so both in men and in women. What is the consequence of these changes? The consequence is that when you give a drug, you're going to have initially high concentration of the drug, but once the drug is there, it is going to have a prolonged effect. And that means that medications have to be administered carefully, especially the opioids or drugs like gabapentin and many of our anesthetic drugs. Now, this is a topic that is very close to my heart. And if you look at propofol, and I know we don't use that for pain management, but we use it for so many other reasons, sedation and other things. You know, the effect that a dose of propofol or the recommended dose or decrease that should happen in an elderly patient is about 30 to 75%. So is true for etomidate, so is true for fentanyl, so is true for remifentanil and also dexmedetomidine. So two of our analgesic drugs and one of our anti-anxiety drugs should be decreased by around 50% in elderly patients, whether they are administered intraoperatively or postoperatively. Now we come to the third part, preoperative evaluation. So we have elderly people who have decreased reserve and multiple comorbidities. Furthermore, they are frail. And how do we define frailty? I think the simplest way to look at frailty is that it is a representation of neuromuscular degeneration. Once that degeneration happens, tends to increase with age, as seen by many studies, and now there are umpteen number of studies which suggest that if the more frail you are, the more likely are you to suffer complications in the perioperative period. Now, age, comorbidities, and frailty are less likely to be modifiable factors, but some of those are, some of those can be optimized, but in many situations we cannot optimize them. Furthermore, these patients are taking multiple medications, hence any new medication that is added in the postoperative period is going to cause can potentially cause drug-drug interactions and lead to multiple side effects. This is the population that is coming to us. We then further expose them to anesthesia and anesthetic drugs, and then we propose them to surgery. So when they come to us in the preoperative phase, these are complex patients, and what we have to determine is what are patient-related factors that are going to affect their analgesia after surgery, and what can we do preoperatively, or what information can we collect preoperatively or intervene preoperatively to educate as well as plan for the postoperative period. So, number one, many of these patients suffer from conditions like osteoarthritis or cancer pain and are already taking chronic pain medications. So, one of the key things is to determine what is their morphine equivalent dose that they are taking. They could be taking oxycodone, they could be taking morphine, they could be taking hydromorphone or hydrocodone or tramadol. And this chart basically tells you what is the equivalence. And the importance of that equivalence will become apparent in just a few slides down. So, for example, if somebody is taking PO 120 milligrams of tramadol for pain, they are taking approximately 25 milligrams of PO morphine. Okay, if they are being given 10 milligrams of IV morphine, they are getting 25 milligrams of PO morphine or sublingual morphine, and so on and so forth. So this chart basically describes the equivalence of morphine equivalent dose. Furthermore, what we really do want to find out is what are their other issues. Frailty, we talked about that. We want to know about their comorbidities, especially if they have kidney disease, because that is going to affect what pain medications, opioid or non-opioid, we can use, whether they have cancer pain, whether they have neuropathic pain, whether they have dementia and Alzheimer's, or other neurodegenerative disease, which could either make them more sensitive or less sensitive to the side effects of pain medications that are going to be used. Very important is to determine whether they suffer from anxiety, depression, or any other behavioral things, and their cognitive capacity, because if they are don't have good cognitive capacity, they may not be able to use things like PCA. They may be more prone to the side effects. We also have to keep in mind what kind of surgery they are going through, and if the surgery is amenable through nerve blocks or epidurals in order to manage pain, and whether anticoagulation or antiplatelet drug is in some way going to limit our ability to use medications or invasive procedures to help with the pain. I'm not going to talk about different nerve blocks. That is a very broad and different topics. With that in mind, one can potentially create an analgesic plan, and that analgesic plan will be, hey, okay, what are the multimode pain management, pain medications that can be used, and whether it's going to be combined with regional or without regional anesthesia. And typically we would follow the same pathway that is mentioned in the World Health Paradigm. You initially would start with non-pharmacological pain management. That is usually less effective, but you'll add non-opioids. But even though the interventional pain management, and here we consider nerve blocks and neuroaxial blocks, this may be something that in the perioperative period, and especially in the elderly, may have to be considered before surgery happens or just before surgery happens, or around the time of surgery, and then followed by non-opioids, mild opioids, and strong opioids. All right. So once we have that and we have a probable analgesic plan, then we can go ahead and start educating our patients or the caregivers. We have to inform them about the severity and duration of pain that they are likely to suffer based on their surgical incision and surgery. Number two is, which is very important, is to explain and to let them know that what are the kind of side effects they are likely to suffer. Now, keep in mind, these are the side effects that they are likely to suffer from opioids and opioid type drugs, and that could be very disturbing for them as well as their caregivers. And I think the other part, which is not really mentioned too much, is to set the expectations. The goal should not be to make them absolutely pain free, because if we try to achieve this, then we are going to probably end up causing a lot of this as well. Uh, uh, the side effects can also include things like renal failure or renal insufficiency, especially if non-steroidals are used. So something to keep in mind that we should have done. So coming back, what are you going to educate the patients about? You're going to tell them, hey, what is the severity of pain that they're likely to suffer? What is the duration of pain that they're likely to suffer? What are going to be the side effects of some of these multimodal analgesics that we are going to use? What could be the drawbacks and side effects of regional or nerve blocks that we're going to be using? And what is the expectation of what the pain is going to be like and what the control of pain is going to be like? And that we are trying to balance the side effects with having zero pain and so on and so forth. So this is the thing. Now we think that this should help the patient, educate them. However, one should keep in mind that there are no high level uh, randomized prospective control trials which have shown conclusively that this helps or improves outcomes. And part of the reason is that we're dealing with large variability, and for various reasons there are many confounding factors, and but I think this falls into the category of informing the patients well, and informing the caregivers. Now, you also have to inform them about risks of complications, and this is where determining how much opioids they were taking before comes into play, and what kind of psychiatric or surgery that they are going through. So, let me take you through this. So, there could be an individual who could be opioid tolerant. This is typically defined somebody who's taking 60 milligrams of morphine equivalent dose in the last 7 days to manage their pain. Opioid exposed is defined as somebody who's taking 60 milligrams of morphine equivalent dose in the last 90 days. And opioid naive is somebody who is taking 60 milligrams and may have taken that more than 90 days or is already, so hence the effects of opioids is not there. Now, the risk, the second part is you have to determine their modifiers. If they have history of psychiatric history, substance abuse history, if they're going through surgery like thoracic surgery, spine surgery, which can have a lot of pain and chronic pain, or if they have behavioral tendency where they think about pain significantly, then you can give them multiple points, and each one of these things is going to be a point. So if they have 0 points and they are opioid naive, the chances of having complications related to pain management are low. They can be managed with multimodal pain therapy. However, if they have one modifier, which is usually one of these, then they may benefit from preoperative psychiatric, psychological counseling and modification. And if they have two or more, then they are at very high risk, or they are at high risk of developing complications, and essentially would require multimodal pain therapy, psychological counseling preoperatively and may benefit from a pain consult in the perioperative period for advanced pain management techniques, and so on and so forth. And as one can see, we can manage the same protocol for somebody who's opioid exposed, and those who are opioid tolerant, irrespective, are at very high risk of sustaining complications related to opioid and non-opioid pain management, and they will be difficult to control pain, and hence are more likely to get more pain medications and end up with more complications. And hence you have to approach them not only in terms of managing the pain pathway, but also the psychological or emotional component, as well as using other especially invasive modalities to manage their pain. So my final recommendations in summary are that when you are assessing these individuals, take a good pain history, determine their medications, determine the drugs that they're using, what is the morphine equivalent dose, what are the risks that they are likely to suffer. This ONET is basically the last slide that I talked about, and essentially determine if they benefit or potentially benefit from pain specialist consult or psychosocial therapy, and essentially setting that up. In the immediate preoperative period, again, inform them about expectations, educate them how difficult and severe the pain is going to be, consider preemptive multimodal analgesia, and try to use the lowest possible dose. One thing, if you forget everything else, but keep one thing in mind, that elderly patients require much less dose of opioids and non-opioids because of CNS changes and their pharmacokinetic and pharmacodynamic changes. With that, I stop. Thank you so much for allowing me to participate in this wonderful conference. And if you have any questions, feel free to email me. Thank you.